I will be taking you through the progression of heart failure, the various compensatory mechanisms that are operating in heart failure, the benefits and the adverse consequences in long run leading to worsening of heart failure. As we know that heart failure is a condition in which the heart fails to pump adequate blood to meet the body's metabolic demands, or it does so at a higher filling pressure. So as the cardiac output declines in heart failure, the compensatory mechanisms are activated, which are primarily of two types. One, the sympathetic or the adrenergic nervous system, and two, the renin-angiotensin-aldosterone system. The activation of sympathetic nervous system causes release of norepinephrine and other catecholamines into the circulation, and these catecholamines act on various alpha-1 and beta-1 receptors that are expressed in the blood vessels, heart and kidney. The stimulation of beta-1 receptors of the heart increases the contractility, increases the heart rate, and this enhances the stroke volume, the cardiac output, and helps to maintain perfusion to various organs. So this is beneficial in short term. However, the drawback is that the long-term action of norepinephrine on these receptors increases the workload on the heart, because as contractility increases, the myocardial oxygen demand increases, the energy expenditure increases, and this places strain on the ventricular muscle, so the workload increases and the contractile function of the heart decreases over a period of time. Another reason for a decrease in contractile function is that chronic stimulation of beta-1 receptors of the heart causes desensitization and downregulation of beta-1 receptors. So the number of beta-1 receptors on the membrane decreases, and this decreases the responsiveness of the beta-1 receptors to the adrenergic stimulus, and therefore the contractility of the heart decreases over a period of time because of reduced number of beta-1 receptors on the membrane of the heart. Likewise, stimulation of alpha-1 receptors that are expressed in the systemic arterioles increases the arteriolar tone. When the arteriolar tone increases, this helps in the redistribution of cardiac output to the central nervous system, the coronary and the renal vascular beds. So, stimulation of alpha-1 receptors that are expressed in the systemic arterioles increases the systemic vascular resistance. When the systemic vascular resistance increases, the heart has to contract forcefully to overcome the resistance, and this places strain on the heart. This generates tension in the ventricular wall, and tension in the ventricular wall increases, and this increases the workload on the heart, and the afterload increases. So afterload is related to systemic vascular resistance. When the systemic vascular resistance increases, the afterload increases, the workload on the heart increases. In addition, activation of sympathetic nervous system stimulates the beta-1 receptors of the kidney, causing release of renin. Renin is also formed due to the activation of the renin-angiotensin-aldosterone system in response to a decline in cardiac output. So, increased renin formation causes conversion of angiotensinogen to angiotensin 1, which in turn gets converted to angiotensin 2. So, angiotensin 2 produces multiple effects that favor sodium and water reabsorption by the kidney and helps to regulate blood volume. As we can see in this figure, angiotensin 2 stimulates the adrenal glands to secrete aldosterone, and aldosterone acts on distal convoluted tubule of the kidney, causing reabsorption of sodium and excretion of potassium. Angiotensin 2 also stimulates the posterior pituitary to secrete vasopressin, which is an antidiuretic hormone. This is responsible for the formation of water channels in the collecting duct, causing reabsorption of water by the kidney. Also, vasopressin stimulates the thirst centers, and this stimulates increased water intake and increases the blood volume. So, through these actions, angiotensin 2 helps to regulate blood volume, maintain cardiac output, maintain perfusion to various organs, and this is beneficial in short term. However, chronic high levels of angiotensin 2 can increase the blood volume, can cause hypervolemia and volume overload. So as the blood volume increases, the end diastolic volume increases, the end diastolic pressure increases and preload increases, because preload is related to end diastolic volume. As the end diastolic volume increases, the preload increases, the cardiac output increases, and this places strain on the heart and can cause diastolic heart failure. Do remember that angiotensin 2 is a potent vasoconstrictor. So by increasing the peripheral vascular resistance, by increasing the systemic vascular resistance, the afterload increases, because systemic vascular resistance is related to afterload. When the systemic vascular resistance increases, the afterload increases and workload on the heart increases. Therefore, increased cardiac workload is a common finding in heart failure. Increased cardiac workload is due to increase in afterload, increase in preload, increased contractility, and increase in heart rate. So, when the systemic vascular resistance increases, the afterload increases. When the end diastolic volume increases, the preload increases. When the contractility increases, the myocardial oxygen demand increases and the workload on the heart increases. When the heart rate increases, this places strain on the heart and increases the workload and oxygen consumption, thereby increasing the workload on the heart. So in long term, the myocardial oxygen demand, the cardiac workload increases, and this reduces the performance of the heart. This decreases the contractile function of the heart. So with the progression of heart failure, the cardiac workload increases and further damage to the heart in presence of high levels of norepinephrine, angiotensin 2 and aldosterone can result in cardiac remodeling. Cardiac remodeling is characterized by change in the shape and size of the ventricle. So the shape and size of the ventricle is altered because of increased workload and damaging effects of neurotransmitters such as norepinephrine, angiotensin 2 and aldosterone. The changes that occur in cardiac remodeling are proliferation of connective tissue cells, growth of abnormal myocytes, deposition of extracellular matrix such as collagen, proliferation of fibroblasts that causes fibrosis in various organs such as myocardium and kidney, and this causes structural changes in the heart and the kidney, causing a functional decline in these organs. In a failing heart, cardiac remodeling causes death of the myocytes, and the remaining myocytes are subjected to increased workload and stress, and this decreases the performance of the heart over a period of time. So as heart failure progresses, the workload on the heart increases, the cardiac remodeling can cause further damaging effect on the heart, decreasing the function and the performance of the heart and affecting the perfusion to various organs. The three primary manifestations of cardiac remodeling are dilated cardiomyopathy, hypertrophic cardiomyopathy and restrictive cardiomyopathy. Dilated cardiomyopathy is due to volume overload. As the blood volume expands, there is dilatation of the ventricular walls and thinning of the ventricular walls. And because of thinning of the ventricular wall, it weakens, there is weakening of the ventricular wall, and this can lead to a decline in the systolic function and can cause systolic heart failure. The next type of cardiomyopathy is hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, there is increase in the myocardial muscle mass and myocardial wall thickness increases. The hypertrophy of the myocardium helps to improve the perfusion of the heart, helps to maintain cardiac output, but over a period of time, the contractility of the heart decreases, the filling of the ventricle decreases, and this can lead to systolic heart failure or diastolic heart failure. The next type of cardiomyopathy is restrictive cardiomyopathy, where there is stiffness of the ventricular wall, loss of elasticity and decreased compliance. This impairs the ventricular filling during the diastolic period, and a small increase in the diastolic volume can increase the diastolic pressure, increasing the diastolic ventricular wall stress, leading to diastolic heart failure. So diastolic heart failure occurs in restrictive cardiomyopathy. Do remember that unlike dilated cardiomyopathy, there is no alteration in the size and shape of the heart, and also the ejection fraction is preserved. The defect is in the ventricular filling during the diastolic period, and this causes heart failure with preserved ejection fraction. With the progression of heart failure, the cardiac workload increases, there is cardiac remodeling, and this decreases the performance of the heart and the performance of the kidney. So the heart is no longer able to pump blood in the forward direction and maintain adequate cardiac output. The compensatory mechanisms fail to maintain perfusion to various organs, and this causes the heart to fail further, and the heart failure is termed as decompensated heart failure because the compensatory mechanisms, the adaptive mechanisms fail to maintain perfusion to various organs, and this can lead to organ failure as a result of decompensated heart failure. In decompensated heart failure, since the heart is not able to pump blood in the forward direction, blood is retained in both the ventricles. In the left side of the heart, the blood retained in the ventricle builds up pressure in the lungs, and this causes transudation of fluid into the lungs, causing signs and symptoms of shortness of breath, cough, dyspnea, fatigue, reduced exercise tolerance, and pulmonary edema because of transudation of fluid into the lungs. So this causes crepitations in the lungs as signs and symptoms of the left-sided heart failure, which is related to the lungs. On the right side, blood is retained in the right ventricle, and this builds up pressure in the peripheral circulation, causing the fluid to move out into the interstitial tissue, causing edema in the lower limbs. Cardiomegaly can occur because of cardiac remodeling and congestion in the heart, and also there is accumulation of fluid in the intestine, decreasing the absorption and decreasing the motility of the intestine. Thus, in decongested heart failure, the signs and symptoms of congestion is seen, and this ultimately leads to organ failure because the heart fails to maintain the perfusion to various organs, and this ultimately leads to systolic or diastolic heart failure. So, with the initiation of heart failure, the compensatory mechanisms are activated, and these compensatory mechanisms are useful and beneficial because they help to maintain the cardiac output, maintain perfusion to various organs, and is helpful for the body to maintain the cardiac output. But these compensatory mechanisms become self-defeating in long term. Chronic high levels of norepinephrine, angiotensin II and aldosterone are detrimental. They can increase the workload, they can cause cardiac remodeling, fibrosis in various organs, leading to structural and functional decline in various organs. So the heart now enters into a state of decompensation where the compensatory mechanisms or the adaptive mechanisms fail to maintain perfusion, and it enters into a vicious cycle, and the signs and symptoms of congestion are seen, and this can ultimately lead to organ failure. So this is all about the progression of heart failure from the initial compensated to the decompensated phase where the signs and symptoms appear and finally organ failure occurs. If you find this video useful, please like, share and subscribe. Thank you for watching.